Good morning, everyone. This is Dr. Mwala again. Today, we're going to be talking about the nephritic syndrome. The aims of this lecture are that by the end of the lecture, we will have revised some of the clinical syndromes that are known to be manifestations of glomerular injury. We will define the nephritic syndrome, look at some of the etiologies and presentation of the nephritic syndrome, and then we'll use post-group A streptococcal glomerulonephritis as a prototype for the nephritic syndrome. You will recall from my previous lecture that I had said that there are several manifestations of glomerular injury. Injured glomeruli may result in patients presenting with either proteinuria or hematuria. At times, patients may present with both hematuria and proteinuria. When these are present together with other signs or symptoms, they may result in clinical syndromes that are known to be manifestations of glomerular injury. These clinical syndromes include the nephrotic syndrome, which we had talked about the last time. Secondly, may present as the nephritic syndrome, which we're going to be talking about today, or may present as isolated hematuria or isolated proteinuria, or may just present as renal failure. So, the nephritic syndrome is a manifestation of inflammation going on at the level of the glomerulus. In other words, glomerulonephritis. By way of definition, we need to remember that it is not a disease, but a syndrome, meaning that we have a collection or a constellation of signs and symptoms that associate together but can have a varied causation or etiologies. The hallmark of the nephritic syndrome is the presence of glomerular hematuria. Other things that may be present are edema, renal dysfunction, as well as hypertension. When all these four features are present together in a patient, the patient is said to have a full manifestation of the nephritic syndrome. We can look at the causes of the nephritic syndrome as being either primary, meaning that the cause emanates from the kidney, or secondary, meaning that the cause of the renal damage is as a result of disease that is systemic. Primary causes of the nephritic syndrome include the most common chronic glomerulonephritis in children, which is IgA nephropathy, also membranoproliferative glomerulonephritis, as well as idiopathic crescentic glomerulonephritis. Secondary causes of the nephritic syndrome include post-infectious causes, things like post-strep glomerulonephritis, but the nephritic syndrome can also be associated with mycoplasma infection, salmonella infection, syphilis infection. Take note of the subacute bacterial endocarditis. When we recite the features of subacute bacterial endocarditis, in addition to the Janeway lesions, the Osler's nodes, we often mention the presence of hematuria. So that hematuria that we see in patients with subacute bacterial endocarditis is a manifestation of an underlying nephritis. Other causes may be viral, so infections after hepatitis B, hepatitis C, EBV, CMV. Parasites may also be associated with a nephritic picture, parasites such as schistosoma and the more chronic forms of malaria. Fungi and rickettsial infections have also been described to be associated with the nephritic syndrome. Secondly, you can have connective tissue disorders, things like HSP, which, if you recall from our last lecture, we said is a vasculitic condition that manifests with purpura in the pressure areas in the gluteal area, the thigh area, and may present with macroscopic hematuria as well as abdominal pain. Other connective tissue disorders include things such as lupus, check up the 2019 new classification system for lupus, but essentially we know that it presents with the malar rash, may present with anemia, with thrombocytopenia, with oral ulcers, mental derangements. So that can also present as a nephritic syndrome. Other sorts of vasculitic disorders such as antiglomerular basement membrane disease, microscopic polyangiitis, or polyarteritis nodosa may also present with a nephritic picture. Then we have hematological dyscrasias, things such as thrombotic thrombocytopenic purpura, as well as hemolytic uremic syndrome and serum sickness. Be sure to look up the difference between thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. That would make a very good MCQ question. In terms of presentation, patients with the nephritic syndrome, we said, have the hallmark feature of having glomerular hematuria. This hematuria may be either microscopic, meaning we can't see the blood in urine with our naked eyes, or indeed it may be macroscopic. The blood may be bright red, but more often associated with dark colored blood in the urine, which is known as Coca-Cola colored urine. Patients will also have reduced urine output, hypertension, and edema. Other features that are associated with the primary cause of the nephritis may also be present. So if our patient has HSP as the cause of the nephritic syndrome, we may find purpuric lesions in the gluteal area and the thigh area. If the cause is the lupus, we'll find the malar rash and other features of lupus. In terms of the pathophysiology of the nephritic syndrome, it is postulated that it is associated with either a type 2 or type 3 hypersensitivity reaction. And you remember that when we talk about those types of hypersensitivity reactions, we're talking about the presence of antibodies and antigens. So what happens is that we have an antigen-antibody complex that forms and then gets deposited in the glomerulus, gets trapped in the glomerulus. And once it's trapped in the glomerulus, it activates or triggers the complement system. And once that's triggered, inflammation is triggered. And once inflammation is triggered, we get production of chemoattractant molecules, including cytokines, including components of the complement system. And this leads to an influx of inflammatory cells such as monocytes and neutrophils into the area where those antigen-antibody complexes are trapped. And they sort of ramp up the inflammation further, such that we get more production of cytokines. In addition, these inflammatory cells release reactive oxygen species, metalloproteinases, and other substances that are contained in the granules. These substances destroy the matrix around of the interstitial tissues, the mesangium, and that leads to damage at the glomerular filtration barrier level. Because of this destruction to the filtration barrier, it means that the surface that's available for filtration is reduced, and therefore the glomerular filtration rate drops. So it means that fluids are retained in the body. In addition, it is postulated that some of the cytokines that are produced during inflammation actually are delivered to the distal parts of the nephron and modify the function of channels such as the epithelial sodium channel, so that they become primarily activated and therefore increase reabsorption of sodium and water. And this then also further contributes to a situation where the patient retains salt and water and therefore becomes intravascularly overloaded, and this then would lead to edema as well as hypertension. Because the filtration barrier is destroyed, it develops leaks, and these leaks allow the flow of red cells and white cells and other soluble molecules in the plasma. they flow into Bowman's space and eventually appear in the urine. In addition, because the red blood cells have to pass through these leaks, they get distorted, and that's what leads to what are known as dysmorphic red blood cells in the urine. Also note that some of the red blood cells and white blood cells get trapped in the tubules, and together with the tubular protein, the TAMS phosphoprotein, they are formed into casts, and this is what explains why we find cellular casts, red blood cell casts, mixed casts, white cell casts in the urine of patients with the nephritic syndrome. So if we look back at all those etiologies of the nephritic syndrome, if we were to sit down and go through each and every one of them in detail, we would be here for a month. And so because of that, I picked on one disease, which is post-strep glomerulonephritis, to use as an example of the nephritic, a condition that causes the nephritic syndrome. Why? Because it is the commonest cause of the nephritic syndrome here in our low resource environment. It is an old disease, and so I hope that we can glean some lessons from this old disease. As doctors, as students, as scientists working in 2020, we often take it for granted, all this scientific information that is available at the click of a button, and we sort of just take it for granted that this information, was handed down on a silver platter. It's always been there. But that's not the case. And the history of post-strep glomerulonephritis illustrates this point very well. So the first paper that is shown, the history of albuminous nephritis, was actually authored in the middle of the 19th century, mid-19th century. Very interesting paper. Intriguing, a bit long, but essentially it's a review of how people began to associate the presence of edema with renal disease. So this gentleman goes back all the way into the ancient world, quotes Greek fathers of medicine like Hippocrates, Galen, and is able to see how people stumbled and fumbled and faltered to try and associate edema with kidney disease. Finally gets to the place where Dr. Bright in the UK identified the kidneys as a possible cause of edema, or what in those days was known as dropsy. So it's an interesting article which ends with the author sort of theorizing that the possibility of the fact that patients who are recovering from scarlet fever develop this dark urine, the possibility that this could be a problem with the kidneys should be investigated. Very interesting paper. And then the second paper actually has a very interesting literature review, which again reviews the history of how finally people then realized that patients that had suffered from scarlet fever had this latency period before they developed their dark urine, and some of them stopped passing urine. They also theorized that possibly there could be some kind of allergic reaction, and then they changed that to thinking that it was actually like an immune reaction. They managed to develop autoantibodies. It traces the history of the people that actually proved that firstly that scarlet fever was caused by streptococcal infection, and then finally we get to this paper that is an experimental study that simulated post-strep glomerulonephritis pathological features in rabbits. So these guys injected antigen antibody complexes into rabbits, and they were able to simulate the pathological features that are seen in post-strep glomerulonephritis. Very interesting paper. You don't need to remember them for the exam, but just illustrates how important even simple observations as we see our patients are. Good note taking, always maintain your curiosity. So this post-strep glomerulonephritis by now has been proved to occur as a post-infectious non-suppurative complication of group A strep infection. It's now known that not all strains of group A strep will cause it. They're actually nephritogennic strains. To this day, nobody knows for sure what the antigen that actually causes nephritis or the nephritogennic antigen is. It has not yet been confirmed, but candidates along the years have included things like the M protein. Why the M protein? Because you remember that there are certain M protein strains associated with nephritis, whereas others are associated with rheumatic fever. So naturally, they thought that it might have something to do with the M protein. More recently, we have begun to see reports of people developing the nephritic syndrome after infection by non-group A strep bacteria. So patients with strep group C can develop rheumatic fever as well as glomerulonephritis. So obviously then that brings into question the fact that these M proteins are actually the antigen that people have been searching for. So in recent times, the favorite antigens now are what are known as the streptococcal pyrogenic exotoxin B and its zymogen precursor. So these ones have been co-localized with C3 and immunoglobulin G in these special features that are seen in the biopsies of patients with post-strep. So because they are present where there's all this inflammation happening, they were a prime candidate as the possible antigen, and also the fact that they are able to induce an immune response when injected into the blood of subjects also made them a favorite. But there are still some other studies which have found that they're not expressed in all patients with post-strep glomerulonephritis. So the search is still on. So just a bit of a recap in terms of pathophysiology. We've already talked about it, but it is thought that it's either a type 2 or a type 3 hypersensitivity reaction. So we have either antigen-antibody complexes that are preformed that get trapped in the glomerulus, or more likely that we have antigen, bacterial antigen, that gets trapped in the basement membrane because the postulated antigen is a cation. So remember, the glomerular basement membrane has anion sialic groups that repel negative molecules. So if you have a positive molecule, your antigen will be sucked into will be able to traverse the glomerular basement membrane more easily. And then that will be, because the body has formed antibodies against that particular antigen, the antibody will be able to follow the antigen through the glomerular basement membrane and then form the antigen-antibody complex in situ. Whatever the case, whether it's a type 2 or a type 3, the point is we end up with these antigen-antibody complexes in there, and again, they lead to in situ activation of local complement, and then with complement production, chemoattractants, we get cells flooding, inflammatory cells such as neutrophils flooding into this area, causing further inflammation, causing damage, and we get clogging of the capillary, of the loop capillaries with neutrophils, and we get activation or proliferation of resident cells such as mesangial cells, endothelial cells, and we end up with what is known as endocapillary proliferative glomerulonephritis. Now, when this happens, we affect the filtration barrier, and as we said earlier, that reduces the glomerular filtration rate. There's also primary activation of certain channels that lead to increased reabsorption of sodium. And because of that, we get fluid retention, edema, hypertension. So the epidemiology of this post-strep glomerulonephritis, it can either occur as an epidemic or sporadic. Mostly it occurs as a sporadic thing, meaning that you suddenly just get one person, two people being affected in a community, whereas an epidemic, it occurs in large numbers at the same time in a closed community, in a camp, in a boarding school, in a college. And the prevalence of post-strep glomerulonephritis has been falling in developed countries, and this has been attributed to two factors. One, improving socioeconomic circumstances such that there's less crowding, because remember, post-strep glomerulonephritis is mostly associated with strep skin infections. So if you have better housing, less crowding, you get less of that. So you get fewer manifestations of skin infections, and therefore fewer manifestations of the glomerulonephritis. The second factor is that in certain countries there's fluorination of their water supply. So because of that, that fluorination kills some of or inactivates some of the streptococcal surface antigens. So therefore we get less infection. So it's now more a problem of poor communities and low-income places such as ourselves. The estimated incidence is about 10 cases per 100,000 population per year, and it's found to be more common in boys than girls. No one knows the reason. No one knows why. And it tends to occur mostly in school-going children between the ages of 5 to 15. Median age about 7 to 8. Rarely occurs in children who are less than 2 years. So in terms of the clinical presentation, remember that you can get post-strep acute glomerulonephritis either after throat infection or after skin infection. So if it's occurring after skin infection, the latency period is between 3 to 5 weeks, whereas if it's post a throat infection, the latency period is shorter, about 2 weeks, so 7 to 14 days. And the majority of cases actually are subclinical, but for those unfortunate few, they develop the acute nephritic syndrome. It is the commonest cause of the nephritic syndrome in our environment. So remember what I said. Nephritic syndrome is the presence of hematuria, hypertension, edema, and renal dysfunction. So that's the full-blown nephritic syndrome. It doesn't mean that just because that's the definition, every single patient will present with all four features. So this paper gives us an estimate of the proportions of patients with this glomerulonephritis that present with each of these features. So almost everyone, that's why we say it's the hallmark of post-strep glomerulonephritis or the nephritic syndrome, had hematuria. Edema was noted to be present in 90% of patients. Same thing with hypertension, between 80 to 90%. About 30% of patients who present with cerebral complications of hypertension. They may present with PRES, they may present with hypertensive encephalopathy, hypertensive retinopathy, like that. 5% presented with pulmonary edema. About only 20% had raised creatinines, whereas 34% of patients presented with nephrotic range proteinuria. They presented with nephrotic range proteinuria doesn't mean that they presented with a nephrotic syndrome, but the urine, they had massive protein losses in the urine. Some of those did not present with the other features of the nephrotic syndrome. Only about 5 to 10% of patients who have the full-blown nephrotic syndrome as well. And then 50% of patients had oliguria. Note, not anuria, but oliguria, a reduction in urine output. This graph is from that same paper that we've been looking at, and it essentially just shows us the clinical course of post-strep A glomerulonephritis. So as you can see at the bottom, that shows us the time in weeks. and it shows us the various symptoms. So we can see that the latency period is indicated there, and it varies depending on whether the preceding infection was the throat or the skin. Edema, hypertension, and hematuria tend to occur at the same time. They last for about 2 weeks. After that, we see, the hypertension and edema about 2 weeks. After that, we see that there's recovery. Hematuria may actually persist for up to 2 years after the initial presentation, whereas you can see there's proteinuria, which actually appears, like it can appear earlier than the hematuria, and then it may last for up to about 6 weeks after the initial infection. Take note of the topmost graph, which is showing us the drop in C3, such that by the time patients are presenting to us, about 90% of them will have a decreased C3. And then we see that rise in the ASOT titers, all features of the post-strep glomerulonephritis. In terms of management, as usual, we want to investigate the patients. So remember, when patients come to us, we won't be able to tell that, oh, this is post-strep glomerulonephritis. So all we'll be able to say is, we think this kid has nephritic syndrome. And if they have nephritic syndrome, the next thing that should come to our minds is that list of etiologies. And we should cast the net wide so that we do not miss anything. So therefore, remember, from that list we had talked about HUS. We're interested in this full blood count so that we look at the HB. Has it dropped? We are interested in the platelet count. Has that dropped? What's the white cell count like? Is there a possibility of some kind of infection? We're interested in the urea, the electrolytes, the creatinine, because remember we said reduction in renal function is a feature of the nephrotic syndrome. So we want to do that. And we also have a patient who has presented with edema. We want to differentiate. Is this a person who has nephrotic or it's nephritic? Which one is it? So we'll do the albumin, we'll do liver function tests. We want now diagnostic tests. So the complement proteins C3, C4 will help us to differentiate. Obviously, if it's post-strep, we expect C3 to be low, but C4 to be normal. Look up situations where you expect to find both C3 and C4 low. Situations such as, for example, when you have lupus nephritis, if you have shunt nephritis, if you have subacute bacterial endocarditis. Those two may be low. And then we want to do ASOT titers and anti-DNase B. We expect those to be high. A single ASOT that is raised is not very diagnostic, because even people who are just carriers may have a raised ASOT. So what you want, if you've got money, is to demonstrate that the titers of the ASOT are rising. ASOT is more associated with throat infection, whereas anti-DNase B is more associated with skin infection. We want to do urine microscopy to look for dysmorphic red blood cells and red blood cell casts, white blood cell casts as well. And then we want to look at the kidney structure. There are features that there's chronic disease in the kidney. So we'll do a kidney, ureter, bladder ultrasound. Then we're interested in doing a chest x-ray. Remember those connective tissue diseases, things like microscopic cholangitis, antiglomerular basement membrane disease, even SLE, for example, they can cause a pulmonary renal syndrome. So you want to check for hemorrhagic lesions in the kidneys, in the lungs. Other reasons why you might want to is to check for things like pulmonary edema, although you can diagnose that clinically. And then you may need to do a renal biopsy. I'll talk a little bit later about the indications for doing a renal biopsy. We rarely ever do renal biopsies for patients with post-strep glomerulonephritis, but a bit later we'll discuss some of the reasons why we might have to. So you might then want to have a look at some pictures of what pathological specimens for patients with post-strep, those who are unfortunate enough to require a renal biopsy, what their pictures look like. So this is from the Atlas of Renal Pathology. used according to the terms and conditions for use. It belongs to the National Kidney Foundation. Nothing has been altered on these slides, and they're being used for teaching purposes. So we can see this is a low power view of a renal biopsy. Can you see those round things with dots? Those are glomeruli. That's not normal. There's hypercellularity. Not over the tubules so much, especially over those round things. There's a lot of dots. Those are nuclei. So there's hypercellularity over the glomeruli. Okay? And then this is another slide, which is at high power. I think this is times 40. And I think it's silver, but I have to confirm. Again, from the National Kidney Foundation, Atlas of Renal Pathology. So here we can see that the glomerulus looks lobulated. There are a lot of cells. There's infiltration of neutrophils, and also there's an increase in nuclei. And then also of note, remember when we are looking at nephrotic syndrome, remember how the capillary loops looked open, right? You could see white areas and you could easily identify the loops of capillaries. We can't see that here. The loops are clogged. So there's proliferation of mesangial cells, endothelial cells, and infiltration of neutrophils, which is known as an exudative picture. So this is what is known as endocapillary proliferation. Okay, so this is a feature of post-strep glomerulonephritis for those patients who are unfortunate enough to need a renal biopsy. So why would somebody need a renal biopsy? Remember that graph that we had, which showed that complement goes back to normal by about week 6, but we like to give people time to recover, so we give them an extra 2 weeks. So if by 8 weeks after first presentation, the patient has not recovered their complement to normal levels, you might want to do a biopsy to see whether they have some other thing rather than post-strep. Then if, for example, patient presents with nephrotic syndrome, we know it can occur in post-strep glomerulonephritis, but it's a rare occurrence, so you want to do a biopsy. And then remember again from that clinical course chart, by really week like 6 or so, significant proteinuria has gone away. So if by 6 months after your patient has significant proteinuria, you want to do a biopsy. If your patient presents with what is known as rapidly progressive glomerulonephritis, you would need to do a biopsy. So remember that yes, we see about 20% of patients coming in with increased creatinine, but often when you see these patients, you won't really find creatinines that are through the roof, that are crazy high. You'll be getting mildish rise in creatinine. But if you see a patient who on admission has a creatinine of 100, you repeat after 48 hours, the creatinine is now 500, creatinine the next day is 1000, that is a patient with rapidly progressive glomerulonephritis. It's an emergency. It's a nephrological emergency, and there are a myriad of other things apart from post-strep glomerulonephritis that can cause it, and it has a specific histopathological picture known as crescentic glomerulonephritis. So you would need to do a biopsy. If you demonstrate those crescents affecting more than 50% of glomeruli in the specimen, that confirms that your patient has has crescentic glomerulonephritis. Then you would need to use heavy immunosuppression with methylprednisolone plus or minus cyclophosphamide to try and stop the inflammation, because if you don't, 80% of patients will progress to end-stage renal disease. And then if you see suspicious extrarenal manifestations, so if we have a patient that comes in and we think that it's post-strep because the history is typical, they say that they had pustules on the legs, and then they had Coca-Cola color during, things that would make us think, oh, this is post-strep. And then suddenly they develop purpura. they start coughing up blood. That is not part of what we expect. That would make us want to do a biopsy. And then we expect, because most patients have mild renal dysfunction, that by 6 weeks, most would have recovered their renal function back to normal. If they don't, that could be an indication for renal biopsy. Note here, and I refer back to that graph that showed us the clinical course of this condition. Patients may continue to have microscopic hematuria, not macro, but microscopic hematuria for up to 2 years. And that is not a cause for too much worry, and it is not an indication for biopsy. So management for these patients is largely supportive. So we know that it's a post-infectious, non-suppurative phenomena, but nonetheless, these patients may be colonized. In fact, I think, if I recall correctly from the literature, about 20% of patients that are cultured at presentation will still have viable bacteria on their throats or skin or whatever. So therefore, it means that they are infectious. So if they're in a household, they can pass it on to their other siblings, or if it's in a boarding school, to the other learners. So because of that, you want to eradicate possible infection, and so you are going to give penicillin for 10 days. If the patient is allergic to penicillin, as usual, we use erythromycin. And then we go back to looking at the pathophysiology of this condition. There's retention of salt and water. So obviously, if we want to reverse the edema and hypertension, we're going to have to fluid restrict the patient and reduce the amount of salt. So the strategy is almost like we're managing renal failure, really. So just like for for AKI, we say fluid restrict to 400 mils per meter squared per day. On the first day, that's what we're going to do. On the second day, we'll have the records available to us. We'll be able to estimate how much urine the patient passed, how much fluid they may have lost from other sources, if they have maybe an active NG tube or any other source of fluid loss. Then we'll add that urine output, any other source of fluid loss, plus insensible loss, which is our 400 mils per meter squared, to decide for the next day what their fluid restriction will be. And then, because of the mechanism, which is essentially retention of sodium and water, we want to reverse that mechanism. And one of the most powerful ways of doing that is by giving a loop diuretic, which will block the sodium chloride potassium channel in the thick ascending loop of Henle, and therefore lead to loss of water and sodium. So furosemide is our drug of choice. If, in addition to the benefit of controlling the edema, it will help us to control the hypertension. However, if the control of the hypertension is not optimal, we are allowed to add on other agents. Agents of choice include calcium channel blockers, things like amlodipine or nifedipine. Stay away from potassium-sparing drugs such as AC inhibitors and angiotensin receptor blockers, because those ones will reduce the already reduced glomerular filtration rate even further, worsening the situation, and they may also increase potassium, because remember, they lead to retention of potassium. Thiazides are not very useful in this situation. Don't give them. Stay away from spironolactone. It's potassium sparing. And then remember that 35% of patients may actually present with cerebral manifestations of hypertension. So please be prepared. Go and revise management of urgent and emergent management of hypertension. For those, we are going to use IV antihypertensives. Our hydralazine, we rarely use it at UTH, but nitroprusside, sodium nitroprusside, and look up other IV management drugs for hypertensive emergency. And then, as we manage this patient, we keep in mind that what we're doing is expectant management. It's when we say conservative management, doesn't mean we go away for 4 days. It means every day we need to weigh the patient, we need to do meticulous monitoring of their urine outputs, we need to meticulously examine them, check whether they are severely fluid overloaded, listen to the lung bases, we're checking for pulmonary edema, we'll feel where the apex bit is, has it been deflected laterally. We're going to just make sure that the indications for dialysis have not appeared in this patient. We're going to do bloods every day just to make sure the potassium has not risen. We're going to manage their diet in terms of potassium intake. We are going to manage phosphate intake as we would for a patient with acute kidney injury. Refer to the lecture on AKI. And so if any of the indications for dialysis, the usual indications for dialysis present in our patient, we're going to institute dialysis. So if our patient has hypertension that's not controlled using medical means, if our patient has hyperkalemia, if our patient needs blood products, if our patient is not getting enough nutritionally, so we need to create space for food. If there are any other electrolyte imbalances that can't be managed medically, if we can't manage the acidosis medically, that would be an indication for dialysis. So in terms of prognosis, the prognosis is said to be good, with less than 1% of children developing chronic kidney disease, although there are now controversies on this statement, with papers saying that most of the methods that were used in earlier studies were flawed and that patients were only followed up for a very relatively short period of time. And so people are re-looking at this to demonstrate whether indeed post-group A streptococcal glomerulonephritis is really as benign as we have always thought it to be. So to recap, we have revised the fact that there are 5 clinical syndromes that are a manifestation of glomerular injury. We have looked at the fact that the nephritic syndrome means that you are dealing with inflammation at the level of the glomerulus. We have defined the nephrotic syndrome as the presence of hematuria, hypertension, edema, and renal dysfunction, with hematuria being the hallmark of the syndrome. And then we talked about the fact that there are numerous etiologies of the nephritic syndrome that must be kept in mind. And we have seen that in our Zambian setting, the commonest cause of nephritic syndrome is post-strep glomerulonephritis. And finally, we ended the lecture by discussing the epidemiology, pathogenesis, clinical features, investigation, and management of post-strep acute glomerulonephritis. Please refer to Moodle for your quiz. There will be 5 questions on this lecture. Good day.